Alterations in elimination gastrointestinal, disorders of the upper gastrointestinal tract. Anorexia is actually a lack of appetite. It's not the disease that we think of, which is more of a mental issue called anorexia nervosa. It is a lack of appetite. If it is prolonged, though, it can lead to malnutrition. The appetite center is located in the hypothalamus and it stimulates or suppresses the appetite. Glycogenolysis is going to convert glycogen to glucose during periods of reduced food intake. In the older adult, anorexia can occur from ill-fitting dentures, fewer taste buds, and less active taste buds. So basically, clients with anorexia have an absence of hunger. Nausea might be present, and they also will experience hypovitaminosis. So we look at their lab work. We're looking at their hemoglobin. It will probably be reduced. We're looking at their blood cell counts and their electrolytes and their protein levels also, just to make sure that everything is relatively good. So the treatment is going to be dependent on the cause for the anorexia. Short term, really, there's nothing we need to do. But there are various approaches for persistent anorexia, including a high-calorie diet and or supplements, or enteral or parenteral feedings. They may require psychological or psychiatric treatment. And there are some prokinetic agents that we can administer to help stimulate the appetite. One of those comes in a pill, or we can give it intravenously. It is actually designed to prevent nausea and vomiting, but it also promotes movement of substances through the GI tract and increases that GI motility. So one of the effects is it's going to increase hunger, and that would be metoclopramide. There is another medication that is available. I don't have it listed here, but sometimes we will administer a drug called Megace, Megace, and that is also an appetite stimulant. So it is very important that when a client does have anorexia, that nurses monitor potential consequences from anorexia, such as constipation or diarrhea, and we may need to consult the dietitian. True or false? Anorexia is a lack of appetite and can result in malnutrition. And we know that is true. Nausea and vomiting has a lot of common causes and they often occur together. Nausea will usually precede vomiting. When someone becomes really nauseated, they're getting ready to vomit, they usually are going to have some increased salivation. Their skin gets cold and clammy, and they may have tachycardia from vasoconstriction. They will have a loss of appetite. They may have dehydration if it goes on too long. This could potentially be caused by a bacterial or a virus, and could be caused from bowel obstruction, in which case the abdomen is going to be distended, firm, tender, and bowel sounds would be either hypoactive or completely absent. We need to look at the blood levels, so we're going to especially look at the serum levels of sodium and chloride. If nausea vomiting is prolonged, we may need to give IV fluids. may need to replace some electrolytes, and we may need to use some medications, some antiemetics to help with eating disorders or help with the nausea vomiting. Gastrostomy tubes are going to be used for a variety of things. They're going to provide a route for nutrition. We can give medications through them. We can do gastric decompression or compression. We can do a lavage. A lavage is basically, well, let me tell you about the time that I have done lavage. We put a nasogastric tube down. Someone has a gastrointestinal bleed in the stomach area that just will not stop. So we put this tube down, and now we begin to instill cold IV fluids, usually normal saline or lactated ringers, and then we suction it right back out. But that cold, we know, causes vasoconstriction, so it should and theoretically will slow bleeding down. Excuse me. We can also put a tube down to perform diagnostics or for other treatments. So placement, we know the nasogastric tube is going to go down through the nose all the way into the stomach. An orogastric tube would go in through the mouth, or we have a nasoenteric tube that would go into the intestine. We could put in a gastrostomy tube. This is placed surgically because it will go in through the abdominal wall directly into the stomach. Some of these gastrostomy tubes are called a PEG tube, a G tube, or a jejunostomy. The type of tube that is used will depend on the reason for the placement. If there are going to be long-term feedings, we know that feedings can be given by bolus, so we can give a large amount at one time. We can do it intermittently to, for example, match meal times. We can do it cyclic, or we can do it continuously. If it is done continuously, we will definitely be using an electronic infusion pump to do that. The head of the bed should always be elevated with tube feedings to help prevent aspiration. So the head of the bed needs to be elevated at least 30 degrees. If the client complains of abdominal cramping, then that means one of two things. Either the fluid is too cold or it's going too quickly. So it's important to slow the rate down in those instances. Gastroesophageal reflux disease, aka GERD. This is where the gastric contents are going to regurgitate into the esophagus. It usually is caused by lower esophageal sphincter insufficiency. In other words, the sphincter is no longer able to close appropriately, and it allows contents from the stomach to come back into the esophagus. Well, what's in the stomach? Hydrochloric acid. So when those contents come back up into the esophagus, then it causes burning because the esophagus is not designed to handle the acid. Things that will increase the incidence include obesity and pregnancy. There is a risk of esophageal bleeding with GERD or Barrett's esophagus, which is a precursor to esophageal cancer. The pain from GERD can be similar to a myocardial infarction. These clients are going to have pain in the epigastric area, so basically in the area below the xiphoid process, and it will be a burning pain generally. And they may also have some regurgitation depending on how severe the GERD is. We can do barium swallows, an upper endoscopy. We can do biopsies with an upper endoscopy. We can also do a capsule where they swallow the capsule and then it travels through the gastrointestinal system, taking pictures as it goes. And then they will actually uh, excrete it in the feces when it gets all the way through. But it will send pictures to a computer that has been directed to accept those pictures. And we can also do a bronchoscopy to determine if any um, contents have been aspirated into the lungs. We need to start off treating this conservatively. We don't want to just jump in right away and start potentially doing surgery, etc. We are going to start off with some medications. There's a lot of medications out there. One of the surgical procedures is called a Nissen fundoplication, where they repair a hiatal hernia or repair the area where the GERD is located. They can also do what we call the Stretta procedure. But some of the medications we might use would be the proton pump inhibitors, excuse me, such as omeprazole. The thing about omeprazole is these caps, they come in a capsule, but those capsules can be opened and dissolved if we need to administer them through a tube. We can do prostaglandin analogs, such as misoprostol. Misoprostol is going to help reduce gastric ulcers or heal duodenal ulcers. The thing about misoprostol is it can cause uterine cramping. So this medication is definitely contraindicated for any pregnant female. Again, it can cause uterine contractions. In fact, working as an obstetrical nurse, misoprostol is the medication that we would use to help ripen the cervix and or initiate labor. The next type of medication would be a mucosal protectant. This is a really great medication. It basically creates a barrier in the stomach. So foods and acids cannot get to the area that has been injured and needs to heal. It can be given in a pill form or a liquid form. Unfortunately, it does require multiple doses throughout the day, and it needs to be administered 2 hours after other medications and 1 hour prior to meals for it to be really effective. This medication is called sulcrafate. We also have the H2 receptor antagonists that are used to treat GERD and peptic ulcer disease. That would be like our ranitidine or famotidine. And of course, we have our antacids. Antacids, of course, can be bought over the counter, as can your omeprazole and some of your famotidines or ranitidines. But they can also be prescribed. So your antacids, be aware that, we know that taking too many antacids can actually lead to metabolic alkalosis if people take too many of them. So it needs to be taken judiciously, and people need to know that it can be harmful if they are not careful when they take it. The thing about antacids is they are pretty inexpensive compared to some of your other medications. However, they also have to be administered frequently uh, to maintain the effect. So, as far as nursing management, we should encourage our clients to eat smaller meals. When the stomach is over full, it's more likely to regurgitate or that the contents to just kind of boil back up into the esophagus. We should also avoid foods that increase gastric acidity, such as our peppers, coffee, and alcohol. We should also avoid foods that may allow for reflux, which include, again, alcohol, chocolate, citrus fruits, and high fat foods. We should encourage clients who are overweight to lose weight and avoid eating or drinking within 30 minutes of going to bed. Um, After they eat or drink, they should remain in an upright position for at least half an hour to allow gravity to aid in that digestive process. True or false? Gastroesophageal reflux disease is where gastric contents regurgitate. This is true. Esophageal cancer is a cancer that will affect men more often than women, and it's basically a squamous cell carcinoma. There is a strong correlation to alcohol abuse and smoking. A lot of these clients are asymptomatic until that cancer progresses and begins to interfere with swallowing. We diagnose it by doing that barium swallow, doing a biopsy, doing an EGD, a bronchoscopy, an endoscopic ultrasound, or a mediastinoscopy. We treat it with surgery, chemotherapy, radiation, and if they're not a candidate for surgery, palliative measures would be appropriate. As far as nursing actions and management, we need to consult with dietary. These clients are going to require a soft diet, in other words, nothing too difficult to swallow, but they also need a high calorie, high protein, and semi liquid foods. They may require liquid supplements. They should not drink from a straw or narrow-necked bottle because that's only going to increase some of their issues. And then we need to prevent some postoperative complications. And hopefully by this time you all know what postoperative complications I'm talking about. Gastritis is going to be an inflammation of the stomach lining. It's caused by some foods, medications, infections, or stress responses. There is a bacteria called Helicobacter pylori that may contribute to chronic gastritis and increased acid production. It can also lead to ulcer development. These clients are going to report fullness, abdominal pressure, pain, nausea, and vomiting. Understand that the symptoms will be the same whether it's bacterial or viral. And these clients are going to have bleeding from medications or poisonings. We can look at a CBC, we can do a gastroscopy, and we can also do stool tests to help diagnose this. The treatment will be dependent on the cause. It may require some dietary restrictions, IV fluids, depending on how significant the issue is. Medications may be required to help soothe the irritation and inflammation. Excuse me. They may require antiemetics if they have nausea, vomiting, or antibiotics if it is a bacterial infection. They may need clear liquids or electrolyte solutions to replace fluids that have been lost. As far as nursing, it's very important for us to note the color, characteristics, and amount of any vomitus or stools in someone with gastritis to make sure, number one, there's no blood in there, and to make sure that there's no other issues going on. And then provide appropriate client education on diet and therapy. It is very important to educate our clients on appropriate infection control measures such as hand washing. We also need to encourage them to sanitize surfaces, appropriately wash their dishes, and properly wash, prepare, and cook foods because some of the infections may come from the kitchen. Peptic ulcer disease is going to be a loss of tissue from contact with hydrochloric acid and pepsin in the lower esophagus, stomach, or jejunum. So, in other words, peptic ulcers can occur in the esophagus, in the stomach, or in the small intestine. They are often caused by an infection of that Helicobacter pylori, maybe a family history, and there are other risk factors such as high stress levels, chronic gastric inflammation. Ulcers are likely to recur unless significant lifestyle changes are made, and it does affect more men than women. These clients are going to have pain, usually in the abdomen, sometimes in the back, and it can disturb their sleep. They may have bleeding from these ulcers, which can be pretty severe. So that means they may have hematoemesis, so blood in the vomitus, melena, which would be blood in the stool, and the pain is going to increase with an empty stomach. So think about this, we have hydrochloric acid in the stomach, and when the stomach is empty, that acid is going to be more likely to interfere with those ulcers. We diagnose with an upper GI, an EGD, maybe a low hemoglobin or red blood cell level. The goals are going to be to eradicate any bacteria and reduce acid levels, provide appropriate pain management and drug therapy. Again, these ulcers can bleed, and they can bleed very excessively. And if we have a client who's starting to show signs of deterioration due to a potential GI bleed, this is going to be lightheadedness, hypotension, tachycardia, tachypnea, um, pale colored skin, etc. Then it's very important to lower the head of the bed. So when we have hypotension, we lower the head of the bed because as we raise the head of the bed, their blood pressure is going to drop even lower. Make sure you get a set of vital signs and then notify the healthcare provider as soon as possible. They are going to require IV fluids and potentially surgery and blood transfusions. Now, with a gastrectomy, sometimes that may be required to take care of peptic ulcers. They go in and they actually remove a portion of the stomach and resect it. Some people who are overweight will elect to have a portion or all of the stomach removed to help lose weight. These clients will begin to develop what we call the dumping syndrome. So if we think about our digestive process, We put the food in our mouth, goes down the esophagus into the stomach. Well, it's going to stay in the stomach for a little while just to begin that digestive process. Then it goes down into the small intestine and works its way through. Well, if we don't have a stomach there, then basically food is going right into the small intestine, or if we just have a smaller stomach, it's going to move through the GI tract much faster. So they develop what we call the dumping syndrome. So it's basically we put food in the mouth and the body just dumps it right back out. This condition can cause weakness, sweating, abdominal cramping, and diarrhea due to that rapid emptying of the stomach or lack of stomach. It can also cause hypotension and hypoglycemia. So it's really important to do dietary modifications, monitor for complications, monitor the client's stools and bowel patterns. These clients need to lay down after eating to help prevent gravity from moving everything through too quickly. Which electrolyte imbalance is common with someone who has vomited? Low sodium hyponatremia.